overall, again, thank you for joining us for today's webinar, Serious Emotional Disturbance, SED, a review of determination and documentation with Shannon Fortran and myself as your presenters. So I do want to take a moment to introduce ourselves. So I'm going to pass it over to Shannon to introduce herself.
Hi, everyone. Good afternoon. I'm excited to be here. My name is Shannon Fortran. I am the director of the Children's Outpatient Unit with the Office of Mental Health, supporting programs like Children's Outpatient Clinic, School-Based Mental Health Clinic, Children's Day Treatment, and I'm excited to talk about SED with you today. I'll turn it back over to Diana.
Thanks. So yes, my name is Diana Arias. I am the Director of Innovation and Education at the Community Technical Assistance Center, CTAC for short, within the NYU McSilver Institute for Poverty Policy and Research. And I support the creation of training and educational resource opportunities for behavioral health providers working with children, youth, and families throughout New York State. And again, also very happy to be here today with you all. So as we get started, just a couple of housekeeping things as well. I want to highlight that we are offering free CEs for this webinar. So in order to be eligible for CEs, there is certain criteria, including being a licensed social worker, mental health counselor, a marriage and family therapist, or a psychoanalyst. You must be in attendance for at least 75% of this webinar. You must be using your own Zoom-generated link, so there's no sharing of links. And for CE purposes, you need to be attending using a computer, as a cell phone is not acceptable for CEs. Those who are eligible for CEs will receive a detailed email within the next 1 to 3 business days. So as we get started, I just want to highlight our agenda for today. So we'll start off with a very brief foundational understanding of mental health in young people and really move our focus to serious emotional disturbance, also known as SED, and then focus on how to determine and document SED in young people. And we'll close out with a case example to really try to bring these concepts to life. Throughout today's presentation, we'll be answering several questions around SED, but the overall goal that we have for you is that you will be able to leave with an understanding of the SED criteria and how to make a determination and the documentation process, including the importance of supporting materials, which may differ depending on the program or site that you'd like to make a referral to. But I do also want to point out that this presentation is focused on how the New York State Office of Mental Health defines SED, right? So so again, just want you all to keep that in mind as we move forward. And before we get started, we did just have a quick poll question that should be popping up on your screen soon. And if you could just take a moment to answer the question, which is, which aspect of determining whether a child meets criteria for SED do you find most challenging? And of the options that you have here, A, interpreting clinical symptoms across settings, such as home, school, and community, accessing functional impairment over time, C, differentiating between trauma responses and chronic mental illness, D, engaging caregivers in the assessment process, or E, applying diagnostic criteria consistently. So again, if you could just take a moment to fill that out. And if there's something that definitely is challenging for you, but it's not listed here, please, again, feel free to share that via the chat box. That would be great. So we're going to have this up for just a couple of seconds, and I'm going to turn it over to Shannon just to share where folks are joining us from today.
Yeah, I'm excited that everybody's writing in and telling us who you are. I'm seeing some familiar names, which is kind of exciting, but it looks like we have a nice cross blend of folks. It looks like we got some state ops, some county folks, EI, school. Looks like I'm seeing some shout outs for CFTSS and Children's Clinic, which always gets me excited. That's great. Good to see you here today. But it looks like we have a nice representation, which I think is really exciting. I think one thing that you'll see throughout the presentation is that we tried to tailor the presentation to educating folks that might be completing the documentation, as Diana said, as a licensed practitioner, or folks that actually might be referring to programs that have SED as criteria. So I think we have a blend of both of that group, which is nice.
Great, thank you. And our results have come in. So majority of the folks that filled in selected differentiating between trauma responses and chronic mental illness as the thing that you find most challenging when determining if a child meets SED. followed by interpreting clinical symptoms across settings, as well as engaging caregivers in the assessment process. So thank you so much. Really appreciate you taking the time to share that with us. All right, so as we move on, let's see. Let's just get going with a little bit of level setting information. So we do know that mental health disorders are common in young people, with a significant portion experiencing a diagnosable condition at some point in their lives. So in the US, data indicates that among 3 to 17-year-olds, just over 11% have been diagnosed with ADHD, 10% with anxiety, 7% with behavioral disorders, and 4% with depression. And furthermore, there is comorbidity. So more than 1 in 3 children have had 2 or more mental health disorders. Despite these prevalence rates, though, many young people are not severely impacted and can actually manage their mental health disorder with minimal impact to their overall well-being or functioning in areas of life. However, there is a specific set of mental health disorders classified as designated mental illness that are recognized as significantly impacting a person's ability to function. And this may help them qualify for certain services and supports that they may need. This distinction I do want to highlight often involves criteria related to the severity and the persistence of the illness, as well as its impact on daily life. So as I mentioned, let's really focus and turn our attention to serious emotional disturbance, again referred to as SED. And again, as a reminder for folks, in case anyone came in late, I do again want to highlight that this is New York State's Office of Mental Health's interpretation definition of what the term SED means, and is essentially used for eligibility for New York State programs. So what is SED? SED is not a mental health disorder. It is a clinical determination for children and youth who meet the following criteria. They have a designated mental illness diagnosis according to the most current edition of the DSM. And they also experience functional limitations due to emotional disturbance over a set period of time that significantly impacts functioning in areas of their lives. In later slides, we'll go into this a little bit deeper, and we'll share what that list of designated mental illness diagnoses are, as well as the functional limitations. But I do want to stress that simply having a mental health disorder is not sufficient to meet the determination for SED. So how might a child or a family member, a child with SED or a family member of a child with SED be impacted? What we see in a lot of young people with SED is that they can encounter certain challenges. So for example, we often see difficulties with emotional regulation, impulse control, including outbursts and unproductive coping skills, aggression, self-harm, social withdrawal. In academic settings, this can play out and impact or lead to poor academic outcomes, school absences, as well as suspensions and expulsions. A young person with SED may also experience low self-esteem and a lack of interest or lack of insight, along with trouble building and really maintaining meaningful relationships due to social and interpersonal difficulties. Risky behaviors, for example, running away, is often associated with youth with SED. And as mentioned earlier, there could be multiple diagnoses that really impact the course of treatment for young folks with SED. Do want to highlight, as I mentioned earlier, too, that it's not just the child with SED, but also the parent and the caregiver that is in that child's life. So what we see for parents or caregivers with SED, also certain unique challenges around caregiver strain due to the physical, the emotional, the financial toll that caregiving can take. And this may look like fatigue, feeling angry or feeling worried about the child's future, as well as financial strain due to maybe health expenses or maybe a loss of income because they have to take days off from work. Caregivers can also feel overwhelmed due to the child's high level of needs. And the relationship may not be the best due to, say, increased parenting stress, right? So all this can result in caregivers themselves experiencing mental health challenges such as anxiety. And clearly the child, the caregiver, the family unit does exist within a larger context, and they may experience stigma surrounding mental health and discrimination against people with mental illness. So moving on in terms of common challenges associated with youth with SED and in their participation in child serving systems. What we do know is that children with SED, and primarily those with very severe high levels of impairment, are often involved in several systems, such as the mental health, the educational, the juvenile justice system. And this can result in difficulty with service coordination. So for example, access to care as a result of financial or insurance barriers or a lack of providers in their area. We also might see siloed service delivery, which can lead to fragmented services, increased costs, poorer patient outcomes for the young person. There's also the need for tailored treatment approaches while also attending to other factors that can be impacting that child, that youth, and their family. So social and environmental factors, maybe food insecurity, housing security, things that we need to also keep in mind. And for transition age youth, navigating the child and the adult systems can certainly be difficult as you're leaving one system towards the other. And sometimes there is not support along the way to do that. In terms of developmental challenges, I do want to highlight that all teens, all young adults struggle with the same development milestone, regardless of there being an SED determination. The difference is that for those with SED, they're challenged by severe functional impairments. So what does this look like? There could be delays in psychosocial development, including identity formation or social development, due to those difficulties with emotional regulation or behavioral responses and social skills. It might be challenges in abstract thinking. So planning for the future might be difficult for young folks. And also feeling like they might not be successful, but like a disappointment to themselves or to their parents, to other individuals, and feeling like they're going through these things on their own, right? So a lot of that sort of social isolation. So given these potential challenges and concerns, it's important to understand that serious emotional disturbance, SED determination works so that a young person with significant mental health needs can receive the specialized supports that they need, not to survive, but really to thrive. So the determination helps providers or helps folks to identify young individuals who need the specialized supports and services, but can also help to identify those services that are best suited to treat their needs. So here's really what it boils down to. SED in New York State is the eligibility criteria for specific programs in New York State intended to support children and youth with complex needs and their families. So okay. So here's a list of those specified or specific programs that require an SED determination. So we have programs across several different, settings per se. So we have community support services, which would include children's community residence and home and community-based services. We have outpatient mental health services, such as day treatment programs, and inpatient services, including hospital-based programs and residential treatment facilities. So there's a huge range of services and supports designated to really address the young person's mental health needs and enhance their overall well-being. If you're not too familiar with how to connect to these programs, don't worry. Later on, we'll actually also include and share links to how to connect to these programs and how different application processes. So we'll touch base on that a little bit later. But before we move on, I do want to point out that while these programs are important, are critical, there are still other programs within the full continuum of services that the Office of Mental Health offers in New York State, which can certainly help to support young people and their families. So you're not fully limited to these programs if there's a determination for the youth with SED. So with that understanding, in terms of SED and its purpose, I just want to move on to who makes a determination. What's the criteria for making that determination? So in terms of who can make the determination, well, the determination is made by a licensed practitioner of the healing arts, also referred to as an LPHA, who has the ability to diagnose within their scope of practice under New York State law, or certain licensed practitioners under the supervision of an LPH. So here you'll see a list of different positions under each of those categories. And as a reminder, you don't have to take screenshots or anything of the sort. The slides will be up in the next 3 to 4 business days so that you can refer to them if you'd like. What I want to highlight here, though, is that licensed practitioners have a vital role here, right? So if you are a practitioner who's joining us, if you receive the request or if you want to make the request on your own, in order to support an SED determination, you need to complete a comprehensive assessment, as well as provide documentation that indicates the significant impairments in functioning in terms of the life activities for that young person. However, if you're already working with a young person, you don't need to create a whole new assessment, right? You can work off of what you have, but for those that are just maybe meeting the child for the first time, it's about completing a really comprehensive assessment and that supporting documentation. And additionally, as I mentioned a little bit earlier on, and we'll get to it a little bit later on, there are some specified requirements depending on maybe that best program or the program that's best suited for the child, along with supporting documentation that really is needed to make a referral to a specific program or a level of care. So in terms of the SED criteria, as I mentioned earlier, a child or a youth must have a designated mental illness diagnosis, according to the most recent edition of the DSM, and experience functional limitations due to that particular emotional disturbance over the last 12 months on either a continuous or intermittent basis. I know I talked a little bit about this in terms of the designated mental health diagnoses. Here's a full list of them. More often than not, the forms that you are filling out will have these listed, so you probably either have to circle or check off. But again, the slides will be available, but I did want to, again, just sort of remind folks that even if a child or a youth has a mental health disorder, it really has to be one of these that are classified as a designated mental health illness. So did want to just remind folks about that. And then lastly, in terms of the criteria, here's the sort of the main focus, right? Are those functional limitations. Every individual, every child, every youth, every adult, older adult also experiences challenge across different aspects of our lives at certain points in time. Sometimes it can be more difficult, whatnot. But that's really what's crucial for this criteria, is that we're talking about a young person who has experienced functional limitations due to emotional disturbance over a particular set of time, over the past 12 months on either a continuous or intermittent basis. So the criteria is that at least one of these is met for the young person. So we have one, if the young person is having trouble with their ability to take care of themselves. So we're talking about maybe personal hygiene or obtaining food or eating food. Two, challenges with family life. So maybe issues living in a family or family-like environment, or maybe those relationships with family members, as well as their behaviors in a family setting. Three, difficulty with social relationships. So again, as I mentioned earlier on, maybe establishing and maintaining real relationships, honest relationships, or interpersonal interactions with other folks, including peers, neighbors, adults, teachers. Four, challenges with self-direction and self-control. So this could look like problems focusing their attention for a long period of time in order to complete age-appropriate tasks, or problems with making decisions. And finally, five, challenges with learning. So for example, expressive language or relationships with teachers, or also their behavior in school, right? So how do we function within a school setting per se? So that is a sort of very quick, brief, foundational 101 in terms of what is SED, what is the criteria for SED, who can make that determination. And at this point, I'm going to turn it over to Shannon to talk a little bit more about the actual documentation process.
Thanks, Diana. I get to talk about everybody's favorite topic, documentation. You can't be in this field and not address documentation, right? So we'd be remiss if we didn't address it. So in thinking about documentation, and thank you, Diana, for walking us through what SED criteria looks like, what are the key components to it, I will reinforce that. I think if you're to walk away from today's presentation, the key thing that I think would be really helpful to walk away with is understanding that there's two components to SED. It's not a diagnosis, as Diana pointed out. It is a clinical determination. So you need those two key components of diagnosis and functional impairment. And a very critical aspect of eligibility to those programs that Diana outlined is the documentation, right? You need to be able to demonstrate that a child does meet SED criteria. So We would need a mental health diagnosis from an LPHA, that list of practitioners that Diana outlined, the functional impairments, and documentation of risk factors, which I'll get into in a little bit more detail. And I think, we talked about this early on, but I think, given the people that are attending today's webinar, there are going to be instances, and I think you've probably already experienced this, that as a licensed practitioner, where you will get a referral, maybe from a care manager, from a school saying, this child needs more supports and services. We need you to do an assessment and determine what services they need, and a comprehensive assessment is needed. Or you might just get a call and say, we need you to confirm SED criteria and what that looks like. Or you yourself are working with an individual and you think that they would benefit from more supports and services. So you're the one that's actually making the referral for a program that requires SED eligibility. And that, because of the different ways in which a licensed practitioner can be asked to complete a comprehensive assessment, or might be engaged in a comprehensive assessment to determine SED, it can be documented in a variety of ways, right? It could be, in the assessment itself. It could be in a treatment plan if you're already working with a youth and you're recommending additional supports and services. It could be in a discharge summary and a narrative summary. So it could be captured in a variety of ways. And we'll talk about that in a little bit more specificity. So to drill down into the core components of what makes up SED documentation, again, we have the designated mental health diagnosis and functional impairment. Now, I think as a licensed practitioner, one of the questions, and I think I picked up on this a little bit in the chat earlier on, is that one of the questions is, how do you know that the functional impairment is not just the manifestation of the child's diagnosis, right? In order to diagnose a child, there has to be some level of impairment, and there must be some level of symptomology in order to diagnose a child, right? So how do we know that it's not just the diagnosis itself? And how do we know that there's more functional impairment above and beyond that would necessitate an SED determination? And I think Diana said it best when she reinforced the duration and severity, right? A lot of diagnoses are usually 6 months in order to diagnose, and the functional impairment here would be 6 months or longer, and the severity level. So the acuity of the child and the duration in which we're seeing that acuity. So an example is, over the past 18 months, which speaks to duration, Benjamin has difficulty controlling his emotions leading to daily tantrums, such as screaming, crying, aggressiveness towards teachers and peers, resulting in significant time out of school, which might be suspension, which speaks to intensity, right? The next core components would be the recommendation for services. I think one thing I really want to emphasize here is that it's entirely possible that as a licensed practitioner, you get a phone call from a care manager saying, we just need you to verify SED. We just need you to verify SED so we can get the child enrolled in this program. But I think the responsibility of that licensed practitioner is, because that you're not just confirming the diagnosis, you're confirming that that child meets this functional impairment as well, that an assessment is needed. If this child's not known to you, a comprehensive assessment is needed to determine that level of severity and acuity. And maybe the outcome is confirming that indeed that child would benefit from these programs that a care manager or another referral source is recommending. But that might not always be the case, right? There might be other supports and services that could benefit that child, which may or may not require SED criteria, or the child may or may not actually meet SED criteria. They might have other needs. So I think it's really important that it's not just, yep, we're confirming SED here. It's also ensuring that the recommended care and level of care is appropriate to meet those needs. And then any necessary documentation, right? If we go back to Benjamin's example that I just referenced, obviously there's a lot of challenges happening at school, right? If the child's getting suspended, so school reports, if Benjamin has recently been hospitalized, if he's involved in other supports and services, any discharge paperwork or any referral documentation is really helpful too. Okay, so what does the assessment process look like? How do you assess for SED? Well, there is no specific tool for SED, as I'm sure some of you here with us today can attest to. But what is important is a clinical comprehensive assessment. Because SED is not a formal diagnosis, it is a clinical determination. So a comprehensive assessment is still needed if the child is not known, you're not currently engaged in a therapeutic relationship with that child. So what does that look like? It typically looks like a biopsychosocial, right? Interviewing the child and family, having context to that to the family, to the youth, to their environment, to their functioning. So a standard biopsychosocial is likely appropriate. Collateral information, right? Children do not function in a vacuum, right? They attend school, they have family, there's social engagement typically. So ensuring that you're engaging any appropriate collaterals, which might include schools, it might include other practitioners if the child's involved in multiple systems, all of the above, and then obviously treatment history. And that certainly would get at that functional impairment of that persistent functional impairment of over 12 months. So Diana gave a list of programs that are licensed or supported by the Office of Mental Health that do require SED criteria for eligibility. Now, we wanted to be able to provide you with some resources to those services. The thing that we want to highlight here, and we'll give some examples, some concrete examples for you, is that each program will require its own documentation. Some of that is universal. For example, the Children's Community Residence, they utilize a Children's Single Point of Access application, Part 1 and Part 2, so the CSPOA application, if you're familiar with that. So you can use that application for not just community residents, you can also use it for RTFs, Residential Treatment, and Youth Act. And we'll give an example, and we'll give you some links to that. While there are other programs like day treatment, HCBS, hospital-based programs that have specific program documentation. So in those cases, we would recommend for day treatment specifically, but if you're not familiar with day treatment is not just a clinical program, there's also an educational component. So if you think a child would benefit from day treatment programming, liaisoning with the child's home district, their Committee on Special Education, their CSE chair, health home case management, we would recommend reaching out to the local health home organization when we provided a link so you can search by county. For HCBS, there is a HCBS licensed practitioner of the healing arts, LPHA attestation form, and we'll talk through that as well. For the first example, let's drill down to HCBS for the LPHA attestation form. So HCBS, I think a key component for this is if the child is at imminent risk of hospitalization or out-of-home placement. So the necessity for HCBS would help to deter and keep the kid in their home and community. So we give a screenshot of the form at the top of the form, and you'll see that there's a hyperlink to it. Something I want to highlight here, again, that each program might have its own specific documentation to capture eligibility. If you are a referral source, say you're a health home care manager with us here today, and you are providing this form to a licensed practitioner to complete, I would just really emphasize, I'm sure I'm stating the obvious here, but I would really emphasize that you make yourself an expert in the directions and the criteria needed so that one, you can inform that licensed practitioner that might have never heard of SED criteria. And I think, I think it'd be painful for you as well as the licensed practitioner and possibly delay care if you get this form back and it's not completed accurately or completely. So ensuring that you're very familiar with this documentation before supplying it to the LPHA. So I think that this, for HCBS specifically, so I know we talked about this again, but we can't overstate it enough. So in order to be eligible for HCBS, the child must meet SED criteria, right? And we've already talked about that, the mental illness and the functional limitations. But I think a common question that we receive, and it makes sense, right? If you're a licensed practitioner and you have to attest that a child is at risk of out-of-home placement, if not for accessing HCBS services, how do you determine that? Is there a screening tool to determine that? Is there an assessment tool to determine that? And there isn't, right? So I think being able to look at the criteria to make it a little bit more concrete of what are the risk factors to help concretize out-of-home placement and risk of out-of-home placement out of the home and community and a higher level of care, I think is really critical. So HCBS, a child must meet 1 through 4, must meet one of those, and number 5. So the child is either currently placed out of home, including a psychiatric hospital, or they have been placed out of home in the past 6 months. They're currently applying for out-of-home placement within the past 6 months, or there's multiple system involvement like child welfare. And that involvement is required in order for them to be successfully maintained in the community. And then, of course, the narrative explanation. So this is the second part of the LPHA recommendation attestation to be able to bring those pieces together, right? That attesting that they meet SED criteria, that they have the risk factors, and that attesting that because of these criteria, without HCBS, the child would be at risk of a higher level of care. The next example is Youth Act. Now, I'm going to generalize it just a little bit because Youth Act, along with community residents and RTF, all use the same application form, the CSPOA form that I referenced earlier. There's a part 1 and part 2. What I really want to draw your attention to is that there is a tutorial for both parts. There's part 1 and part 2. If you are a referral source that commonly refers to Youth Act, community residents, RTF, if you're assisting a family in accessing these programs, I would certainly encourage you to review these tutorials so that you familiarize yourself with the application and the application process. And then if you have any questions, you can certainly reach out about these specific tools as well. And then last but not least, as part of that process specific to Youth Act, community residences and RTFs, there is the LPHA form. So this is, I think, regardless of the forms for these respective programs, the one key ingredient is that there is an LPHA attesting to SED criteria. And again, that is the designated mental illness and the functional impairment. Let's jump into a case example. So I think another question that we get is regarding when a child has SED, meets SED criteria, and when they don't, and what that looks like. And I know, Diana went into some specificity about that earlier, but, they're at an increased risk of comorbid conditions. They're at an increased risk of treatment failure and dropout. And because of that, because of their acuity, because of that functional impairment, that is why there are these specialized programs, like we referenced before, like day treatment and community residences, that are specialized in treating these conditions. Okay, so let's jump into an example. So I'm going to do a side-by-side, one case example that would not meet SED criteria and the other one that would. So mom notices behavior and mood changes in her 7-year-old daughter, Angela. She's always been a daydreamer and outgoing. Lately, Angela appears anxious, can't focus enough to finish assignments in class, and is having difficulty making close friends. Her 2nd grade teacher shared that her academic performance continues to decline and that peers are isolating themselves from her during recess due to her scattered conversations. Her mother attributes this to kids not liking school and acting out. However, she has noticed similar changes at home. Angela is tangential in her conversations, disorganized with her clothing and toys, is overly worried, and has difficulty concentrating. This heightened inability to focus and stay on task is new to her mother. After consultation with the teacher, her daughter began to see a licensed mental health provider. She's diagnosed with ADHD, is receiving therapy through the school, medication through a psychiatrist. After several weeks, the changes in her behavior and mood are well managed and have significantly decreased. She's also doing better in school. Okay, that's example 1. Example 2, same context, same background. The difference is, since kindergarten, Angela has had difficulty following directions and paying attention to her teacher. As a result, she's received Tier 2 behavioral supports for students within her school, including increased instruction, supervision, and positive reinforcement. Although Angela can strike up a conversation with anyone, she also has a history of struggling to build and maintain relationships with peers. After consultation with the teacher, she began to see a licensed practitioner, and she was diagnosed with ADHD, and the same treatment was recommended. So when comparing the side by side, so there is the diagnosis, right? She was diagnosed with ADHD in both scenarios. The difference here is the functional impairment. And one thing I want to emphasize is I think commonly when we're thinking about functional impairment for SED, I think that there is an assumption that it tends to look like behavioral dysregulation, that it tends to look like outbursts. But I think the one thing that we want to highlight for you all today is that, a child with, for this example, ADHD, there is going to be certain symptomology that you can associate with that diagnosis. I think, one of in the chat earlier that Diana had facilitated, folks said that one of the common issues that they experience is differentiating between trauma response and SED. And I think it's kind of a misnomer, right? It's not separating the diagnosis from the functional impairment. It's that the symptomology of that diagnosis is so severe that it's causing acuity in the child that's leading to functional limitations over the course of 12 months or more. And that speaks to the duration and the severity of the need. So in this case, Angela has shown over the past 3 years that her symptoms has escalated and resulted in functional impairment. And it's going to result in her possibly repeating second grade. So a big takeaway here. Again, if you're going to walk away from this presentation with anything, I would love that you walk away with understanding that SED is not a diagnosis. It is a clinical determination that requires a designated mental illness and functional limitations that are persistent over 12 months. And that this determination, this SED determination, is used as eligibility criteria for specific programs that are intended to keep kids in their homes and communities. And that documentation is needed, right? We always need documentation, but that we would really draw your attention that the specific programs that you'd be referring to or completing documentation for are specific to that given program. So you would have to make note of that. And we have some references and resources here. And then as Diana promised, we do have more links for you to browse. And I think that's it.
Thank you so much, Shannon. Yeah, so we, again, I invite you to put in any additional questions or comments in the chat box. But for now, we'll go with some of the questions that have come in. So let's see, we have a question here. What about a child who has been in and out of the hospital due to outbursts? So we're talking about the ER, but has been living at home. Can this meet the criteria? And there was a follow-up, another participant who definitely seconded that question about the multiple ER visits counting towards SED. They added that oftentimes the feeling is that only getting admitted to the inpatient floor can open up the doors for more specific programs. So Shannon, if you can speak a little bit about admissions to ERs and what that means as part of the criteria for SED.
Yeah, sure. So I do want to reinforce that. So SED, so it's right. So there's I want to clarify one thing. So SED has the diagnosis and the functional impairment, right? That's SED. But then certain programs, and I'm going to jump back to it, like HCBS has specific risk factors that also must be met. So in this case, so if there's multiple system involvement, if the child is utilizing emergency services routinely, right, if they're utilizing mobile crisis, the ER, in order to be maintained in the community, that would fall within the risk factors for SED. So it would not fall within functional limitations or the mental health diagnosis per se, but it would fall within risk factors.
Great, thank you. Wondering if you can talk a little bit about adjustment disorder. So would these qualify as SED?
SED, yes, a designated adjustment disorder is a designated mental illness.
Great, thank you. And there, I guess more so for clarification, can you provide some examples of what would be included in multi-system? So it seems that there's wanting to be clarification between CFTSS and HCBS. Is that what we mean by multi-system?
It is not. So multi-system involvement would be actual child serving systems. So maybe the educational system, maybe the child has an IEP plan, maybe they're involved in child welfare, prevention services through child welfare, juvenile justice. So actual system involvement. If they're already being served within the mental health system and they're co-enrolled in, say, clinic and CFTSS, that would not count as multi-system involvement.
Great, thanks. And so, yeah, there are a good number of questions and a lot around clarification. So again, certainly keep your questions coming in. As a reminder, there are different programs and different programs do have different requirements, whether that's application forms and things along those lines. So that being said, we had a question here asking, so the presence of a risk factor is not outright required for an SED determination, only for certain programs, question mark.
Can you say that again, Diana?
Sure. So they're asking about the presence of risk factors. Is this sort of a standalone requirement for SED determination, or is the risk factor unique to certain programs?
It's unique to certain programs. So SED as it's defined is, as Diana, and I can go back to that slide to make it, sometimes it's easier. I'm a visual person, so sometimes it's easier to visualize it. But it's the designated mental illness as well as the functional impairment. So I can get back to that. So here's the functional impairment, right? So they'd have to meet this criteria. And then they'd also have to have a designated mental illness. And you'll note that not all diagnoses within the DSM actually fall within the category of designated mental illness. You're not going to see substance use here. You're not going to see medical conditions. You're not going to see IDD for the exception of tic disorders and ADHD. So that's when we're referring to DMI. Just like the question earlier about adjustment disorder, it would, a standalone diagnosis in and of itself, like adjustment disorder, like a mood disorder, like anxiety disorder, is not going to qualify for SED. There has to be the presence of a DMI with the presence of functional limitations. Those two combined is what brings the SED determination. Those alone on their own would not meet SED criteria.
And if you can go back to the DMI slide, there was a question, does autism spectrum disorders count? So again, just for folks, we will have these slides for reference, but we do also have in the resource links to other outside sources that you can get this information as well.
Right. And autism diagnosis is not a qualified designated mental illness. So the only neurological and developmental conditions that would qualify is tic disorders and ADHD.
Yeah. And then there was another question earlier on around the impact of substance use in terms of making those diagnoses. So as you said, yeah, it's not listed here, but when there are other presenting problems, I'm wondering if there's any thoughts or feedback around how to make that determination when there is a substance use problem.
Yeah, it's a good question, right? I mean, we want to treat the whole child, but when we're thinking specifically about SED, so we would need the presence of a DMI and addiction disorders. So both substance use as well as addiction disorders are not included as a DMI. However, I think that we can all appreciate that there is often comorbid conditions, right? And thinking about integrated care. So if there is an IDD condition, if there's a substance use condition, an addiction condition, that's fine, but it would need to be co-occurring with a DMI in order to be SED criteria. And then on top of that, so that's one step, right? One step is determining SED criteria, but then the other step is that licensed practitioner has to determine if whatever program or service is appropriate, right? So if a child, say for instance, does have a substance use need, does have an addiction disorder, and does have a co-occurring designated mental illness, and they've confirmed SED, that doesn't necessarily mean that HCBS or day treatment is the most appropriate program to meet those needs. It might actually be a referral to a an Oasis clinic or some other program or service. So I think there's two parts to that, right? Just because they meet SED criteria doesn't always mean that those SED required programs are the most appropriate to meet those needs.
Yeah, I appreciate you highlighting that, Shannon. So a question came in and around whether or not you can speak to wait times for some of these specific programs that are available to youth and adolescents with an SED diagnosis, but similar to what you just mentioned, right? There are other programs across the spectrum. So yeah, if you can talk a little bit about the wait list and maybe highlighting other programs that might be helpful to youth with SED that don't require an SED determination.
Sure. Yeah. And apologies. I'm not as familiar with wait lists. I think it varies sometimes by program, by agency, by region, by county. So I would certainly encourage you to reach out to your SPOA or the program in which you want to refer a child or connect to get a little bit more information. But to your point, Diana, I think that's an incredibly important note to emphasize here is that and let me see if I can get to the list of programs. So while these programs specifically do require SED eligibility for admission, there are so many other programs like Child Serving Clinic, like CFTSS, that do not require SED criteria. So I would strongly encourage, and hopefully you all know this already, and I'm just stating the obvious here, but I would hope that if it is determined that a child would benefit from, say, community residence or Youth Act, that, while they're waiting on a wait list, that's not the only program and support that's being offered to them, because there are other programs that do not require SED that might be appropriate or even more appropriate than one of these programs listed here.
Thank you. All right, so we do have a good number of other questions that are coming in. So our next question, are there additional examples of how to differentiate between mild and moderate severity regarding functional limitation? In other words, how do we know that a client's functional limitation meets the moderate threshold?
It's a good question. Let me see. So everybody can look at the same thing that person's looking at. You guys are really testing it if I remember where the slides sit. Here we go. Let me go back to, here we go. Okay, so for functional, so the question is, so the functional limitations in these 5 categories must be continuous or intermittent over a 12-month period, at least moderate in 2 categories, or severe in at least 1. So I'm going to answer this in a more general and then give some examples. So I think this is why we get this question quite often, which is always fascinating to me. Why do we require a licensed practitioner to determine SED? If it's not a diagnosis, why do we need somebody? If a child, or if you get a referral packet and there's already a diagnosis listed in that referral packet, and there's already clear demonstration that a child has had functional limitations in the past 12 months and risk factors, why couldn't a non-LPHA just fill out the SED form and recommend, say, HCBS? And this question really emphasizes why. Because even if, and I think I said this earlier, even if you have 2 children with the same diagnosis, it could manifest differently. And we know that's for a variety of reasons, right? A child is not just their diagnosis, of course, right? There's contextual factors and how it manifests differently. So having that comprehensive assessment by a licensed practitioner will enable that licensed practitioner to give the clinical impressions and be able to inform whether things are moderate or severe. So there is some clinical determination in here. There is, there's no rubric of, this is exactly severe in this rating, but there are clinical impressions, right? And it more so is the impact on their life, right? So I think, let's think about number 4, because I think this is one of the more common ones. If there's outbursts, right? If the child is having behavioral outbursts, they have maladaptive coping strategies in school, it's resulting in suspension, it's happening at home, a severe, and I think, you know, if you can tie it to outcomes, if the child is looking at possible expulsion, if the child is looking at out-of-home placement because they can't be maintained in their home, if they're being violent and aggressive and it's impacting their siblings and their family's relationship and bonding, that falls within severe category, right? So I think it requires some clinical determination, and it also requires some coordination with other systems and really understanding what the possible impact of those behaviors and that limited functioning could result in.
Great, thank you. Let's see. Sorry. Since DMIs include gender dysphoria, should licensed practitioners or school-based support teams use specific considerations, or are there suggested protocols for referred trans students?
And I think a little bit more. And what do you mean by that? If it's are you questioning the functional limitations as a result of that diagnosis?
So I invite the person who put the question in, if you want to provide a little bit more information, that would be helpful, and we can come back to that for sure.
That'd be great. But yes, to confirm, you're absolutely right. That diagnosis does fall within DMI, just to confirm that.
All right. And then can you talk to what is considered or acceptable as a quote comprehensive assessment? Would this be a psychosocial or something else?
Yeah, absolutely. Absolutely. I think that I'll generally say that yes, a psychosocial would fall within the category, right? Risk factors, doing a risk assessment, violence assessment, a biopsychosocial all falls within the category of a comprehensive assessment. I do want to also acknowledge that oftentimes when licensed practitioners receive a referral for a youth that might meet eligibility criteria for SED, that the program in which you're employed might have its own policies and procedures defining what a comprehensive assessment is. I know that exists in clinics, so I don't want to dismiss that. But yes, to answer your question, a biopsychosocial, also acknowledging risk, violence, screenings is appropriate for a comprehensive assessment.
Great, thanks. Another question for clarification. So just confirming that a patient that only has adjustment disorder would not qualify for SED. Is that correct? I heard that it did, but then I heard that it would only qualify if there was also a DMI diagnosis. So just looking for clarification and confirmation on that.
Right. And so I'm sorry if I confused the listeners. Sorry about that. So it would have to fall, which it does, under DMI. And the one thing I wanted to clarify, which I might have neglected to mention when I first answered the question, is that the diagnosis, and this applies to all diagnoses under DMI, the diagnosis in and of itself does not qualify for SED. There must also be the functional limitations as well. So I just wanted to emphasize that. So apologies for that confusion.
I don't know. And I think maybe if we go back to that list for folks on the DMI, I didn't see ODD on the designated mental health diagnosis. Can you speak on why that is? Don't know if you have any thoughts around that.
It is. Some of these are groupings, right? So it is. It's not a excluded criteria. So the only diagnoses or categories of diagnoses that are excluded in the DMI definition are substance use addiction disorders, medical or other substance disorders, and neurological and developmental, for the exception of TIC and ADHD. But as Diana said, we do have more resources so that you can, when we share the slides, we can provide those as well.
And then there was a question about the example. So I don't know if you want to go to the examples there, Shannon, but let's see. In your example, would that not be an example of masking? And yet the serious functional limitations would still be present if not for the masking due to treatment interventions. So I believe this is talking about, the example, but where it was not determined to be a child with SED. So is it more about the masking? Yeah. So is it the fact that I guess there's not severe functional limitations, but it's the masking of it? and we're missing supports and services that would be helpful to that child?
That's a fair question. And I think that so there's a little bit to unpack here with that. So I don't want to go down the rabbit hole of functional limitations are evidence of the condition, the manifestation of the child's condition, and the symptomologies are severe enough that it's causing acuity and impacting functioning. If the child is masking, I'm not dismissing that that's not a problem and that's not something that can be addressed, but it's not manifesting in functional impairments. And in the degree that would qualify for SED eligibility. That's not to say that the child would not benefit from supports and services at all. But it is not manifesting in a certain level of acuity that would necessitate SED. Now, I know there's more to unpack there, and that's a generalized statement, but that is essentially what you're looking for, is that it's impacting the child's functioning in such a way. You could attribute that, for this example, the child is masking. We see that, right, with comorbid conditions with autism too, right? But we would need to see the presence evidenced of functional limitations.
Great, thanks. And let's see if we can just squeeze in one last question. So as a health home care management agency, our HH states they require this LPHA attestation form and an assessment on how the clinician came to determine they met criteria. But there is no assessment for this. What would DOH determine is appropriate documentation aside from this form?
So I can't speak on behalf of the Department of Health, but what I will say is the comprehensive, and I think, let me just go back there. I know we're running out of time here, but let me just jump back there real quick. I think this is important here to emphasize to answer this question. So in order to, a comprehensive assessment, you're right, there's no SED assessment, but a comprehensive assessment, say the licensed practitioner completes a biopsychosocial, that would fall when they do their narrative explanation, the LPHA, explaining that as a result of a comprehensive assessment, this is their determination. Supporting documentation is key here, right? Appending the assessment that was completed that gives context to that determination is what's critical. So whatever documentation, whatever assessment is completed, there might be other screenings or indicators beyond a biopsychosocial that a licensed practitioner might complete, and that's fine. But I think the supporting documentation is key here.
So in the interest of time, Shannon, I'm just going to ask you to move towards the last couple of slides for folks. If you had any additional questions or comments, there is a feedback form that will be popping up on your screen. So if you can fill that out, that would be great. But on that previous slide there, Shannon, we do have some upcoming events. We have a Flourishing Fridays, which is really geared towards providers to really help you not just survive, but thrive in the field that you work with, because everyone that is doing the work is also experiencing the work to some degree as well. So how can we come together as a community? That's July 25th. I do invite you to visit our website for other additional offerings on a bi-monthly basis. We have offerings for peers, an FPA supervisor virtual cafe, as well as a YPA supervisor virtual cafe. And on our very last slide, I want to say thank you to Shannon Fortran for sharing all your wonderful information with our audience, as well as a big thank you to you, our audience members, for attending today's webinar. Again, as we close out, there is a link as well as a short survey that will probably be popping up on your screen. If you can take the time to fill it out, we do take the time to read your feedback. And again, they do help to inform our future offerings. So again, thank you so much on behalf of Shannon and myself. Have a great rest of your day, everyone.